I've heard from Paul Leach on how to enhance fleet efficiency and patient outcomes. We're now going to explore the strategies to optimise NHS ambulance services and patient transport, focusing on reducing response times and improving coordination sustainability. With us, we have got Paul Channdler, Deputy Director, Net Zero Travel and Transport for NHS England, and Carl Dowling, who is a paramedic, resuscitation trainer, clinical skills and simulation facilitator for NHS England. Carl, if I can just start with you, for a paramedic on the front line, I mean, if you can pick one issue, what is the sort of biggest challenge you're facing, would you say?
I would say meeting call times and getting patients into the hospitals and responding to different emergencies. Sometimes we get stuck at the hospitals, and I know there's different things within the integrated care systems that have been put in place to try and make that easier, so we're not stuck there for so long. But I would say that is probably one of the bigger issues.
So it's that whole kind of flow of moving patients through the system.
Yeah, the flow is struggling a bit at the moment. I think since COVID as well hasn't helped with the pandemic, but I do know that it has improved, been put in place, and some trusts now, I believe, have like a certain time limit where the ambulances stay at the hospital, and then after that, if they get stuck there for too long, the hospital gets fined, so then we have to be let go. So I think it's just trying to find that triage sort of system where we get them into the hospital, and then after that we can transfer their care over to someone else who is able to care for those patients, where we can then get let go and go to the next patient.
So Paul, what approaches are being used to increase the availability of ambulances for emergency response?
Oh, it's a good question. And of course, you know, ambulances being stuck outside hospitals for hours on end is a problem that the NHS has been grappling with for quite some time, although it has got steadily worse. So one of the things we're looking at doing is seeing whether we can reduce the need to convey patients to hospital, working with the London Ambulance Service on a pilot with some of their local hospitals. They found that they were taking on average 5 patients a day to a particular ED, who the only clinical intervention that patient was having was a blood test. They go to A&E, they'd wait for a while outside to get an ambulance, they'd go into the A&E, they'd wait for a few hours, they'd have a blood test, they'd wait for a few hours to get the results, and then they'd be discharged home with no further. It's a familiar story, I'm sure, to many people on this call. So we are trialling now, well, London Ambulance are trialling now, point of care testing in their ambulances. They're using Siemens point of care testing, which they can take a prick of blood from the patient's finger and run a whole battery of blood tests to determine whether that patient actually needs to go or not, obviously supported by an established clinical governance program, and we're about to kick off there. We, modest aims to begin with, avoiding taking 1 patient a day to each of 2 hospitals in the trial and building out from there. That's got big potential, obviously, though, both to reduce the number of ambulances tied up outside hospital and to start tackling some of the causal factors, which are full EDs and a bit further down the line, full inpatient beds as well.
Carl, you were nodding along. Is that something that you welcome?
Yeah, I think that'll definitely improve the outcome, and I think it's going to take time to find the right structure. You know, we're always adapting to different things, and I know it has improved to a point, but it does need to improve a bit more. And I also think that there's other ways we can help with this as well, because I think sometimes people go to hospital that don't need to be taken to hospital. And I think that we can try and help from our perspective when we're not taking everyone to hospital. There are guidance and guidelines that we have to follow. And that's fair enough. And I think that's important to have those. So there are times where we can try and prevent people going to hospital. For example, mental health patients. Not all mental health patients need to be going to A&E. Even ones that need to go to a safe place, there needs to be some sort of infrastructure there where they can have somewhere where they can go, because when a mental health patient goes into the A&E, if they're going through a mental health crisis, even though the A&E is classed as a place of safety, it's not exactly ideal for that person specifically to go into A&E, and it's also not ideal for the patients that are already there as well. And that's just causing more issues and more problems getting patients in that do need to be in A&E.
I think part of the attraction of this project is that it starts to put some control back in the hand of the paramedic crews, the ambulance crews that have got the patient in front of them. There's been lots of approaches over the last 15, 20 years that I've worked in the NHS of designing services that would obviate the need to take patients to A&E, whether they're urgent care centres or same-day emergency care or mental health facilities. But quite often the realities are that paramedics find it very difficult to access those services in the here and now. They'll probably have to try and get someone on the telephone or work out what the local arrangements are in that particular spot they find them in, whereas this kind of intervention starts to put some control back in the hands of the paramedics. They can conduct the blood test straight away, which they're trained to do. They can analyse the results in line with an established clinical protocol, and then they've got the backing and the security to say, actually, this patient doesn't need to go to hospital, rather than spending half an hour ringing around to see whether they've got the urgent care centres open at that point in time, etc. So that's part of the attraction here, and it's scalable as well. If it works in London, it could work in any part of the country.
Can non-emergency transport be used to help reduce the pressure on the frontline services, and how do you make sure that it doesn't impact on the service that they already give?
Really good question. I think there's two ways really primarily that we're testing. One is about kind of discharge planning early on, and this idea has been floating around for at least the last 15 years. Plan with the patient and their relatives potentially. How are they going to get home from their inpatient admission early on in the stay? What typically happens, we've all seen it, the patient gets discharged in the morning by doctor's ward round, and then you start planning for their TTOs and their transport at that stage. And what that typically leads to is delays, and what that typically then leads to is full beds, full A&E. So planning transport in advance, that will reduce actually the number of patients who might need NHS provided non-emergency patient transport for discharge, because actually if you plan it early on with patients and relatives and friends, a number of those can go home by different means. So you'd reduce the number of delays and the pressure on non-emergency patient transport as a result of that. And the other is at the other end of the journey, when, for example, a GP decides that a patient in their surgery needs to go to hospital. Does it need a 999 crew? Very rarely is it actually a clinical emergency, although that seems to be the default option. Call an emergency. So using potentially non-emergency patient transport provision to take that patient, particularly if they're in a place of safety and they can afford to wait longer than an emergency taxi could take them in, so that emergency ambulances can be used for genuine emergencies. And we're running a pilot with North East Ambulance Service on exactly this, using NEPS crews and vehicles to relieve the pressure on emergency vehicles where possible. They've been running this as a bit of an informal program for a year or two, and we're now working with them to formalise that, to have a formal evaluation and to see how might safely the envelope of the range of patients that the non-emergency patient providers can step in and take to hospital on behalf of emergency crews.
Carl, do you want to chip in?
Yeah, I don't know the full ins and outs of why patients are getting stuck in the hospitals. I know the hospitals need to get them out as soon as possible, but that's the mindset of them. And I know that there's risks of patients staying in hospital for too long. So I know that once they've reached that certain point, that they can leave and be discharged. And I know that there are multidisciplinary teams within the service outside of the hospitals, like social services, making things ready for certain patients so that when they go home, they've got a care plan in place, and that can really take a long time to get sorted. And because of that, that also is part of the reason why the A&E gets stuck so long as well, because A&E can't get patients to certain wards because the wards are all busy, all the beds are taken. So I know from a hospital point of view that there is something there that's causing a knock-on effect, and it does stem from getting the patients out of the hospital. And I think that if there was a better way to do that, or working better with multidisciplinary teams outside of the hospital. I think that might improve the area as well.
Charlie, are you wary of them or are you welcoming it? Oh, I don't know if we... Oh, have we got you, Carl?
I think there's positives and negatives to all different things. I think it's a really... Do you hear me?
Yep. Sorry, you just froze for a little bit, so
I think
far
there's
away.
positives and negatives to these different things. I think, we're all trying to go electric. We're trying to better the planet, and we're all... Thank you. I think there are good points, positives and negatives in all these different things when it comes to electric ambulances. I do think it's a really good... I am aware though that when it comes to London ambulance service, it's a different boundary, it's a different and how, let's say, East Midlands ambulance service or West Midlands ambulance service or Yorkshire ambulance service that's on the outside of different towns and cities and whatnot, so I think that when it comes to charging the batteries of these things, I think it's very important that we have like a backup. So right now, when we have to refuel the vehicle, if there was something in place like that, I think that would help with the electric ambulances. But it's also having the facilities to be able to charge them. And because we can't guarantee that we're always going to be in area, because we go from Nottingham to Yorkshire and so on and so forth. I've been to Wales before from West Midlands Ambulance Service. So we do get pushed into different areas, and we would need some sort of structure where we can charge those ambulances if we get pushed out of those areas. Otherwise, we could become unstuck that way. London, I'm sure it works a bit differently. It's a very, very big place. There's going to be lots of areas. The mileage they cover, although it's bigger, it's going to be shorter in terms of how many ambulances there are, where they're located within the city itself, outside the city. But when you go to other places, it's not always a work like that. So I do think a electric ambulance in, before it gets pushed out to the other trusts, there has to be some sort of structure on where and how, and is there a backup? Like, you can go part electric, part diesel. Is it worth doing that? And if people go out of their area, have they got somewhere where they can charge that vehicle? The last thing you want is going to an emergency and then not being able to charge the vehicle. And the hospitals could have charging ports as well. That would be very helpful. If the hospitals had charging ports for the ambulances, when they're on standby, they could easily do that then.
Yeah, we will need charging outside every Type 1 ED, every ambulance station, and we'll need to do that as a sub-regional level, as you say, Carl. You can't set up a charging infrastructure in Nottingham but not worry about what about if they end up in, Derby or somewhere nearby, or Yorkshire or what have you. So part of my team's job actually is to plan with each ambulance trust how they're going to roll out electric ambulances, what charging infrastructure they're going to need, where to be able to support the rolling out. And actually we'll need to build quite a lot of that charging infrastructure before the electric ambulances start rolling out into service for fairly obvious reasons. But we're pretty confident about that, and we're pretty confident that actually, given all of the telematics data that we've received from across the ambulance trusts across the country, that actually these vehicles will have sufficient range.
Subscribe to the channel for more